Let's continue our discussion on a practical approach to thyroid FNA.
When you're reviewing a thyroid FNA, the first question to ask is this nodule benign? Benign follicular epithelium shows an orderly honeycomb arrangement of nuclei with minimal overcrowding and overlapping. And these nuclei are small, round, and dark.
But if they're not small, round, and dark, it's time to move on to the next question. Could this be papillary thyroid carcinoma, PTC? PTC nuclei shows characteristic cytologic features. Cytology can diagnose PTC accurately. If you are not familiar with benign thyroid or PTC, please watch my previous 2 videos. If it's not benign and not PTC, the third step is to ask, is this a follicular neoplasm? Before we dive into cytologic features of follicular neoplasms, let's review a few key definitions. First, hyperplastic nodule, or follicular nodular disease, typically presents as multiple nodules. As seen in this image, there's no fibrous capsules separating the nodule from the surrounding thyroid tissue. 2. Follicular adenoma, usually a single nodule with a well-defined fibrous capsule, shown here. It's benign, so no invasive growth is seen. 3. Follicular carcinoma. Shown in this image, we see invasive growth beyond the capsule. Invasion includes both capsular and vascular invasion. So, to summarize, follicular pattern lesions include non-neoplastic thyroid nodular disease, and neoplastic includes both benign adenoma and malignant carcinoma tumors. Now imagine taking a picture right from the center of any of these lesions. That's essentially what we see on cytology, just a collection of follicular cells. But we cannot see the capsule or determine whether there's invasion. So essentially, cytology cannot diagnose follicular lesions with certainty. When we use the term follicular neoplasm in cytology, the differential includes follicular nodular disease, follicular adenoma, follicular carcinoma, and EFTP, non-invasive follicular thyroid neoplasm with papillary-like nuclear features, and sometimes follicular variant of PTC. Yes, it's a long list, and not always helpful clinically. The brutal fact is that cytology cannot diagnose follicular lesions accurately. What makes a follicular lesion different from normal? It all comes down to architecture. Normal follicular cells are arranged in an orderly honeycomb pattern with minimal nuclear crowding or overlap. In contrast, follicular lesions show architectural changes, especially microfollicles. In cytology, microfollicles are defined as less than 15 follicular cells, arranged in a ring that forms at least 2/3 of a circle. We can also see fused microfollicles in 3D complex clusters. Additionally, we can also see trabecular arrangements, small sheets, even single cells, in other words. The architecture is highly variable. But there's one common feature in these different architectures of follicular neoplasms: nuclear overlapping and crowding. This is the fundamental feature of follicular neoplasm in cytology. On the right, as we saw in the previous video, the normal follicular epithelium shows a clean, honeycomb arrangement, no crowding. On the left, the follicular lesion shows nuclei touching and overlapping, features of nuclear crowding. But wait, is nuclear crowding diagnostic? Unfortunately, no. Even normal thyroid can have microfollicles and show nuclear overlap. Here's a picture of normal thyroid. We can see the size of follicle varies, with some microfollicles, as highlighted in red circles. So focal nuclear crowding is present even in normal thyroid. The presence of focal architectural atypia is not enough for follicular neoplasm diagnosis. We have to look at the whole picture.
Clues that point away from neoplasm include background colloid, cystic changes, mixed follicular cell populations, oncocytic and non-oncocytic, mixed architecture, micro and macro follicles. Essentially, if you see varied cell populations and background changes, you're likely dealing with a non-neoplastic lesion.
As in these pictures, we see macrophages as an indication of cystic degeneration. We also see coleoid, a mixed population of oncocytes and non-oncocytes. This is typical morphologic feature of non-neoplastic thyroid FNA. Clues that point toward a follicular neoplasm include high cellularity with a predominantly abnormal architectural pattern, such as microfollicles, trabecular arrangements, and complex three-dimensional structures. The follicular cells and their growth patterns tend to be uniform, and there's usually scant colloid in the background. In this example, we see a moderately cellular aspirate at low power. On higher magnification, the small clusters of follicular cells form microfollicles with significant nuclear crowding and overlapping, classic features of a follicular neoplasm. This is another example. We see follicular cells forming small sheet and small clusters with significant nuclear crowding, diagnostic of follicular neoplasm. To wrap up, cytologic criteria for follicular neoplasm include cellular aspirate composed predominantly of follicular epithelium with architectural atypia. The architectural atypia can have different patterns, but the fundamental feature is nuclear overcrowding and overlapping. The background has minimal colloid and cystic changes. However, since cytology cannot evaluate the presence or absence of a capsule or invasion, cytology cannot definitively diagnose follicular lesions. A cytologic diagnosis of follicular neoplasm may correspond to various entities upon surgical resection, including follicular adenoma, follicular nodular disease, follicular variant of papillary thyroid carcinoma, NIFP, follicular carcinoma.